Hello and welcome, fellow student doctors. Today we will discuss anti-cancer small molecule inhibitors. In our pre-med days, we dreamed of the day when we would learn how to treat cancers. Well, friends, today is that day. I am super excited to present this lecture to you all. In total, we will cover 16 drugs, but I condense them into categories and will give you a way to recognize and understand them by endings in their names. I know this material is hard to learn. Do not be too hard on yourself. Moving a mountain starts by moving small stones, or here, understanding small molecule inhibitors. You can do this. I believe in you. Let's get started together. To prepare you for test day, you will be able to 1. Understand naming conventions of small molecule inhibitors, and 2. Explain the mechanism of action and side effects for the following small molecule inhibitors. I know it looks like a lot, but we will learn together how to make this material manageable and applicable so you can score big on test day. Let's start with naming conventions. Alrighty, so I'm going to give you a cheat sheet for test day in this slide. Essentially, by understanding the naming convention of these agents, you can usually narrow down the answer choices on test day. Let me show you. So, step 1 is to find the IB in their names. That stands for inhibit, as you can see here with the agent Erlotinib. What does this drug inhibit? Well, you need to look to the left of IB to see what is inhibited. For example, the ending tinib means that a tyrosine kinase is inhibited, as the tin in tinib matches up with the letters in tyrosine. Nice. A similar process can be done for BRAF inhibitors. They end in rafenib. Again, the IB means inhibit, and looking to the left shows that they inhibit RAF, specifically the BRAF protein. The next example is Bortezomib, a proteasome inhibitor. Let the zomib ending remind you of Proteazome. Yes, I spelled Proteazome with a Z, not an S, because scientists named these agents to end in zomib because of the similar sound to proteasome. They had to get fancy after all, right? Only 2 endings left now to learn, with the next being Cyclin. I like this one, as Cyclin means that this drug, Palbociclib, inhibits Cyclin-Dependent Kinases. Great. Lastly, Olaparib ends in parib because it inhibits poly-ADP ribose polymerase, which each letter in PAR representing the target. That is P for poly, A for ADP, and R for ribose. Poly-ADP ribose inhibitor. Nice. Now, step 3. You need to understand that these agents are called small molecule inhibitors because they all act intracellularly. Don't worry, I made a lot of diagrams to highlight this important and often testable concept. Again, I know this material is a lot, but just by knowing the naming conventions of these agents can usually help you narrow down the answer choices on test day. This will become a lot clearer as we go, but let this foundation spark your interest. And now, let's examine EGFR tyrosine kinase inhibitors. So, Erlotinib, Gefitinib, and afatinib are all agents used to treat cancers overexpressing the epidermal growth factor receptor, EGFR. Look at their endings. Tinib, which tells you they are tyrosine kinase inhibitors. Nice. By extension, this means that EGFR is a tyrosine kinase receptor. Let me show you. So normally the cell surface EGFR is bound by a growth factor, which leads to receptor dimerization. Essentially, this activates the kinase activity of the receptor and leads to autophosphorylation of the receptor's tyrosines. See why the EGFR is called a tyrosine kinase receptor? Proteins can then interact with these phosphorylated tyrosines to propagate the signals, such as RAS. All of this activation eventually leads to cellular proliferation. We can decrease this proliferation by administering EGFR tinibs, that is, tyrosine kinase inhibitors, Erlotinib, Gefitinib, and afatinib. Ultimately, these agents inhibit downstream signaling and decrease cancer cell proliferation. If you are worried about remembering the targets of these drugs, look at the title of this slide. Use the E in Erlotinib, G in Gefitinib, and F in afatinib to remember EGF, since these agents target the EGFR. Yay! Notice that these are working intracellularly as well, a point we made on the last slide. This makes sense as the tyrosine kinase domains of the EGFR are intracellular, as you can see here. I am not kidding when I say test makers may ask you simply where these drugs act. Get those easy points on test day. Now, listen closely if you want to score even bigger on test day. The clinical utility of these drugs depends on the RAS protein being wild type, that is, not mutated. Because if RAS is mutated, the cancer can proliferate without EGFR activation, because RAS no longer depends on EGFR signaling to be activated. So the mutant RAS is constitutively active in inducing cancer cell proliferation. Bottom line, if RAS is mutated, then these drugs are of limited use in treating EGFR-positive cancers. Overall, this background makes the clinical uses and side effects relatively straightforward. Basically, use these drugs for cancers that overexpress EGFR, but make sure the cancer has wild-type RAS. Again, these drugs are most effective when RAS is wild-type, a commonly tested point. As for side effects, I like to think of them as epidermal cell side effects. Think about it, these drugs bind to the EGFR, that is the epidermal growth factor receptor. So these receptors are on epidermal cells, like the skin, where a side effect is classically an acneiform rash, and the digestive tract, leading to diarrhea. Again, now let's extend our discussion about EGFR signaling with BRAF inhibitors, which is a little bit more downstream of the signaling pathway I showed you here. Essentially, BRAF signaling is downstream of the EGFR activation we discussed on the last slide. Again, the cell surface EGFR is bound by growth factors, which lead to receptor dimerization. This activates the kinase activity of the receptor and leads to autophosphorylation of the receptor's tyrosines. Proteins can then interact with these phosphorylated tyrosines to propagate signaling, such as RAS. Let's just follow one RAS protein and its signaling pathway. RAS then activates BRAF, which then activates MEK. All of this activation eventually leads to cellular proliferation. This process can get out of control, and excessive cellular proliferation can occur if BRAF becomes mutated. See, if BRAF is mutated and becomes overactive, it no longer depends on EGFR signaling to become activated. That is, it is ligand independent. Moreover, as you can see, this leads to MEK overactivation and subsequently excessive cellular proliferation and ultimately cancer. So, to treat this, patients are given BRAF inhibitors, all of which end in Rafinib, to remind you of their target. Moreover, the first aid book notes that these agents are commonly given with MEK inhibitors. Why? By understanding the signaling pathway, you can now understand why BRAF inhibitors and MEK inhibitors are commonly given together. Clinical medicine is really beautiful when you understand the basic sciences, which aren't so basic after all, are they? Ultimately, these treatments can lead to decreased cellular proliferation. Now, let's talk about clinical uses. These agents are commonly used to treat melanoma. This is one clinical use you should probably know for test day, but it is really intuitive because you understand the signaling pathway. See, BRAF is downstream of the epidermal growth factor receptor. Melanoma involves the skin, so excessive epidermal growth factor receptor pathway signaling leading to cancer makes sense. The side effects are also intuitive. Again, they are epidermal side effects like rash, epidermal skin cells, and diarrhea and nausea, epidermal GI tract cells. And finally, these drugs can also cause fatigue. Okay, now we have another tyrosine kinase receptor, the ALK receptor, or anaplastic lymphoma kinase receptor, a tyrosine kinase receptor. As such, once bound by a ligand, it undergoes similar activation processes with receptor dimerization and autophosphorylation of its intracellular tyrosine. However, this receptor can become mutated and form a fusion protein, where it loses its extracellular domains. This leads to constitutive activation of its intracellular tyrosine kinase domains, leading to excessive ligand-independent cellular proliferation and the formation of cancer. Now, this mutation can be treated with an ALK inhibitor, Alectinib, to decrease cellular proliferation. With this in mind, let's discuss the mnemonic and clinical uses of this drug. Let the AL in Alectinib remind you of its target, ALK. Specifically, this agent is used to treat non-small cell lung cancer with the ALK fusion protein we discussed here. In terms of side effects, this agent is known to cause edema, rash, and diarrhea. Overall, the thing to know about this drug is its target, the ALK fusion protein tyrosine kinase. You're halfway there simply by knowing that the ending -tinib means tyrosine kinase inhibitor. Let's now talk about JAK-STAT signaling in the context of the tyrosine kinase inhibitor Ruxolitinib. Let's start with normal signaling through a cytokine receptor, as all JAK-STAT signaling involves a cytokine receptor. A high-yield point, friends. This receptor is bound by cytokines and leads to the activation of the receptor and subsequently the JAK proteins. Once the JAK proteins are activated, They phosphorylate tyrosine residues on the intracellular domains of the cytokine receptor. Importantly, STAT proteins then become activated and lead to cellular proliferation. Now it makes sense that cytokine signaling is said to occur through the JAK-STAT pathway. Moreover, the JAK proteins are tyrosine kinases, and they can become mutated. This makes them ligand-independent, since they no longer rely on cytokine signaling for activation. Ultimately, this leads to signal amplification and excessive cellular proliferation, ultimately leading to the formation of cancer. Now enter the drug Ruxolitinib, a tyrosine kinase inhibitor, as it ends in -tinib. It binds to and inhibits those mutated JAK proteins, decreasing downstream signaling and cellular proliferation. Now let's talk about clinical indications and a mnemonic. This agent is used to treat polycythemia vera, which involves mainly proliferation of red blood cells, but also platelets and granulocytes. Let me impart this step 1 wisdom to you. Proliferation of red blood cells, platelets, and granulocytes all involve cytokine signaling through the JAK-STAT pathway that we discussed here. Erythropoietin is a cytokine that signals through the JAK-STAT pathway, hence the use of ruxolitinib in treating polycythemia vera where JAK can become mutated. Also, I continuously got this wrong in Q-Banks because I couldn't remember what ruxolitinib was or what it meant. So I used the mnemonic Jackson the Ruxolitinib, named after the toy Jack's in a Box. It seems silly, but do you have a better mnemonic? Jackson the Ruxolitinib. Nice. Actually, friends, if you have a better mnemonic, put it in the comments section at the end of this. I would like to see some creative mnemonics you can come up with because I really struggled with this one. Good luck studying. Lastly, in terms of side effects, bruises make sense as this drug would interfere with platelet production. Why would this drug interfere with platelet production? Because you now understand that platelet production involved the JAK-STAT signaling pathway. It all makes sense once you really understand the basis. Lastly, increased LFTs have to do with how the drug is metabolized in the liver. Let's now cover our last tyrosine kinase inhibitors, BCR-ABL tyrosine kinase inhibitors. Pictured here is a cell outlined in yellow with a nucleus outlined in orange. Pictured inside the nucleus is chromosome 9 and chromosome 22. Watch closely now as this disease process begins when these two chromosomes undergo a translocation. This translocation leads to the production of the BCR-ABL protein, a tyrosine kinase. This mutant protein leads to increased cellular proliferation and subsequently cancer. We can target this mutant BCR-ABL protein with tyrosine kinase inhibitors, ultimately to decrease cellular proliferation. However, as noted in the first aid book, these drugs also target c-KIT. Why is this important? c-KIT is a tyrosine kinase receptor commonly expressed on cells that harbor the BCR-ABL mutation. Thus, c-KIT is a tyrosine kinase receptor that actually resists apoptosis if these drugs only target the BCR-ABL mutant protein. So, by design, these agents listed in the title also target and inhibit c-KIT. Now these cancer cells are less able to resist apoptosis as the therapy has effectively target the BCR-ABL and the c-KIT. Pretty amazing basic science, isn't it? Now in terms of mnemonics and clinical uses, I use the 3-letter mnemonic. See, BCR and ABL are both 3 letters, so I use the first 3 letters of the agents listed in the title used to treat the BCR-ABL cancers. That is, they spell DIN, D-I-N, 3 letters. Yay! Just remember them in sequence. BCR-ABL DIN. Nice. These agents are also used to treat BCR-ABL cancers such as ALL and CML. Moreover, these agents treat c-KIT-driven cancers, mainly gastrointestinal stromal tumors, or GISTs. In terms of side effects, the most notable one is myelosuppression. However, this makes intuitive sense because these agents are designed to treat CML, a cancer of granulocytes. So it makes sense that these agents could ultimately lead to myelosuppression. Lastly, to be complete, these agents are also known to cause increased LFTs, edema, and myalgias. Now, let's talk about proteasome inhibitors, which all end in zomib. So, pictured here is a multiple myeloma cell. Yes, specifically a multiple myeloma cancer cell, as these drugs are commonly tested in the context of multiple myeloma. So listen up. This cancer will tag proteins with ubiquitin for destruction in the proteasomal pathway, as pictured here. To understand this, you must know that multiple myeloma cancer cells produce a lot of excessive proteins. these excessive proteins can build up inside the myeloma cells and signal for apoptosis, that is, cancer cell death. To prevent this, these myeloma cells use proteasomes to degrade these excessive proteins so that apoptosis is not signaled. Doesn't it amaze you how clever cancer cells can actually be? Good thing drug designers are even more clever. By inhibiting proteasomes with these drugs, these excessive proteins produced by the myeloma cells are not degraded, but rather, these proteins build up inside the cancer cells, ultimately arresting the cancer cell in the G2 the M cell checkpoint and subsequently lead to cancer cell apoptosis, that is, cancer cell death. Now, in terms of clinical uses, the cancer to know is multiple myeloma, and that is how these agents will be tested. Make sure you know that proteasome inhibitors are used to treat multiple myeloma. It is very high yield. In terms of side effects, these agents are known to cause peripheral neuropathy and herpes zoster reactivation. The mechanism of this side effect is rather complex, but a way to understand them is that these agents disrupt protein trafficking inside cells, right? So, protein trafficking is actually really important for neuronal signaling, so these side effects may be observed. That is just one way to think of it and how I help keep it straight in my mind. Let's move on to discuss Palbociclib. This agent ends in cyclib to remind you that it inhibits cyclin-dependent kinases, specifically cyclin-dependent kinases 4/6. These two cyclin-dependent kinases are important regulators of the G1 to S phase checkpoint. So, that is why Palbociclib arrests cells at the G1 to S phase checkpoint, ultimately leading to cancer cell apoptosis. In terms of clinical uses and side effects, this agent is used to treat breast cancer and is known to cause myelosuppression and pneumonitis. A lot of cancer drugs cause myelosuppression, and this is blocking the cell cycle, so this side effect makes sense. Overall, just be able to recognize this agent and its mechanism of action, and you should be good to go for test day. Alrighty, congrats friends, we have made it to our last agent, Olaparib. The ending parib is to remind you that this agent inhibits poly-ADP ribose polymerase. That is, parib, the P stands for poly, A for ADP, R for ribose, and IB for inhibits. Altogether, this drug inhibits poly-ADP ribose polymerase. Woo! The importance of this enzyme is in DNA repair. That is why I have pictured the nucleotide excision repair and base excision repair facts here for you. So, since this enzyme is involved in both of these DNA repair processes, it raises the question, why inhibit this enzyme to treat cancer? Well, these two DNA repair processes both occur throughout the cell cycle, as highlighted here. Moreover, cancer cells are rapidly progressing through the cell cycle, incurring DNA damage that requires these two processes to repair that DNA damage. By inhibiting poly-ADP ribose polymerase, these processes cannot fully repair that DNA, leading to an accumulation of damaged DNA within the cancer cells. This accumulation of damaged DNA subsequently causes cancer cell death via apoptosis. Very interesting, huh? Now, in terms of clinical uses and side effects, these agents are commonly used in BRCA cancers, such as breast, ovarian, and pancreatic cancers. BRCA is a protein involved in DNA repair, and Olaparib inhibits DNA repair, so it makes sense that this would be used to treat cancers with BRCA mutations. Lastly, by interrupting DNA repair in the cell cycle, it makes sense that these agents can cause myelosuppression among other side effects. Overall, just be able to identify this agent by its ending and know that the enzyme target is involved in DNA repair. You should be good to go on test day with that information. Wow, that was a lot of information. Let's assess what you've learned now in a flash quiz. The question reads that a patient with non-small cell lung cancer is being treated with Erlotinib, an epidermal growth factor receptor (EGFR) tyrosine kinase inhibitor. Which of the following is a potential reason why this treatment may fail? A. Overexpression of the c-KIT receptor. B. Mutation in RAS. C. Mutation in the STAT protein. Or D. Mutation in proteasomes. The correct answer is B. A mutation in the RAS protein. Looking back at our diagram pictured here, you can see that RAS is downstream of the EGFR, which is what we are inhibiting with Erlotinib. Since the mutated RAS is downstream of the EGFR, it is signaling independent of EGFR activation. a reason why treatment may fail. Thank you for sticking with me throughout this lecture. We covered a lot of material, so this bottom line will focus on essential concepts you must take away from this lecture, starting with naming conventions. You must be able to understand and recognize naming conventions for these agents because on test day, this will usually allow you to narrow down answer choices. So, know that agents ending in -tinib inhibit tyrosine kinases. Of the drugs we discussed today, the EGFR, ALK, BCR-ABL, and JAK tyrosine kinases were targeted. Next, know that agents that end in Rafenib inhibit BRAF, a protein downstream in the EGFR signaling pathway. Also, know that proteasome inhibitors end in Zomib and why they are used to treat multiple myeloma. Next, know that the ending Cyclib indicates that the agent inhibits Cyclin-Dependent Kinases, arresting cells at cell cycle checkpoints. Lastly, know that the ending Parib indicates that the drug inhibits poly-ADP ribose polymerase, an enzyme important in DNA repair processes. And so, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always remember, friends, there is a great big beautiful tomorrow.